A 2-month-old boy is brought to the physician for diffuse erythroderma. Lab studies show reduced chemotactic behavior amongst leukocytes. Which of the following factors is most likely reduced in this patient? Choice A, C1, choice B, C3, choice C, C5, choice D, C9, or choice E, CD55/CD59. I'll wait 5 seconds and answer the question. So for a lot of you, you've probably heard before that C5a is one of the most potent chemotactic factors for various leukocytes, including neutrophils or monocytes. So of course, choice C, C5 is the correct answer here. But obviously I don't want to make this video just to tell you, oh hey, C5a is used for chemotaxis, okay, bye. I want to review the complement cascade at least a little bit. Now in this question, I'm mostly asking you about the classical pathway, and that is probably the pathway they test on most. Honestly, in my opinion, the whole classical alternative lectin pathway stuff is really low yield. I mean, it can come up, but in my opinion, it's pretty rare. But getting back to the classical pathway, you want to know that C1, 2, and 4 are the early complements, and then you go to C3, and then that goes to the MAC complex, which is C5b plus C6 through C9. Honestly, that big picture, I think, is most of what you want to know for an overview. As for specific functions, we can just look at the wrong answer choices here, so we can talk about it. So choice A, C1, like I said, early complements are C1, 2, and 4. If you have a deficiency in these, you can have an impaired ability to lyse encapsulated organisms such as H. flu type B, strep pneumo, and Neisseria meningitidis. Complements 1, 2, and 4 are also relevant in the clearance of immune complexes, so people who have deficiencies in these actually have an increased risk of SLE. Now, some of you might be thinking, well, if I have a deficiency in C1, 2, or 4, couldn't that just affect the downstream and also reduce the amount of C5 flowing around? And that's not a bad way of thinking, but obviously in this question, we have a better direct answer, which is C5. But of course, if you get a question like this, and you can only get one complement as an answer choice, 1, 2, or 4, and then all the other answer choices make no sense, then obviously you would pick that answer choice. I mean, there's some other chemotactic factors you might know about, but honestly, C5a is the one they tend to test on a lot. As a side note, I also want to talk about here, since we're talking about C1, 2, and 4, C1 esterase inhibitor deficiency leads to hereditary angioedema, which is pretty high yield. I mention it here because I don't want you to mix up C1 deficiency and C1 esterase inhibitor deficiency, obviously, because those are two different things. C1 esterase inhibitor deficiency leads to hereditary angioedema, as I said, because it is also involved in inhibition of kallikrein, and kallikrein will lead to an increase in bradykinin, which leads to the common symptoms of vasodilation, swelling, and pain that you see in angioedema. And of course, you also want to know that angiotensin converting enzyme, ACE, is used to deactivate bradykinin, so you don't want to give ACE inhibitors to people with hereditary angioedema because you'll make them surge a bunch of bradykinin and you'll basically cause a flare-up, right? So choices B and D. So as I mentioned, terminal complement deficiency, which is complements 5 through 9, can lead to an inability to form the membrane attack complex, MAC, which is important in fighting Neisseria infections. So when you see terminal complement deficiency, it's usually in the context of some kind of immunodeficiency question. I don't want to get too deep into that because that would make this video like 10 minutes longer, but the short of it is that you do want to know that if you see a patient with recurrent Neisseria infections, so obviously a question like that, they would have a lot of connection to micro as well, but that's basically the only way they can make you identify late complement deficiency, at least as compared to a lot of other immunodeficiencies. So again, anything C5 through C9 would be a terminal complement. Now C3, despite not being part of the MAC, it can lead to similar symptoms because similar to C5, it is upstream. You do want to know that C3b can be used in opsonization, and of course it is also used in activation of C5 convertase, which is what splits C5 into C5a and C5b. So patients with deficiency in C3 can also have symptoms of terminal complement deficiency. So finally, choice E, CD55/CD59. I just threw this in here because it's also related to the complement system. You want to know that DAF/CD55 and MERL/CD59 are used to prevent MAC forming on your own RBCs. So if you have a mutation in the PIGA gene, which can result in a lack of these GPI anchor proteins, it will cause you to be able to form MAC attack complex on your own RBCs, and you will lyse them, and that's what's seen in paroxysmal nocturnal hemoglobinuria. Like I said, I put it here because it's only tangentially related to the complement system, but still something worth knowing. So bring it back, you just want to know what C5a does. It's a very important chemotactic factor, and you do want to know the functions of a lot of the different complements. You just group them together, right? C1, 2, and 4 are the early complements, and then it goes to C3, and then to C5, and then to C6 through to C9. And of course, the big thing here is that you want to know that late complement deficiency, C6 through C9, which can also be affected upstream by C3 and even C5, will cause recurrent Neisseria infections. Hope you found this video helpful. I'll see you in the next one.